Good morning, CHD. Good morning to our viewers and our listeners all over the world. I'm Mike Wynebardakis. This is The Defender in Depth, where we dig deep into the story behind the story from the issues that we all care so very much about. You may find The Defender online at childrenshealthdefense.org/defender. We're also on Substack. You can follow us or subscribe at tdefender.substack.com. And we are on X and on Telegram as Children's HD. And today, first and foremost, is Vaxxed 3 Day. Vaxxed 3, the film where Children's Health Defense embarked on a 9-month journey across America, collecting powerful testimonies from the people that were impacted from the tragic outcomes that resulted from the COVID shots and also from the COVID hospital protocols. Vaxxed 3 hits theaters today. You can visit vaxxed3.org for more information and to see where it is playing near you. Now, it's great to be back after a short break, and for some people, COVID is becoming an ever more distant memory. There's others that are still jostling to get their latest booster and who are still wearing masks, but then there's those of us whose voices are so often not heard, the victims of COVID vaccine injuries and COVID-19 hospital protocols, and of course their family members as well, and also the frontline doctors, the nurses, the hospital personnel who saw these victims get injured or killed up close and who are now beginning to speak up. So today on The Defender in Depth, we have one such person with us. She has taken what she saw, what she experienced as a hospital coder to the media. She's given a lot of interviews. She's been on CHD's Vax on Vax bus. She's written a book that she'll talk about, and she's active on social media, and she's joining us today to share her story and what she's doing about everything that she saw and experienced. That interview, which you will not want to miss, is coming up in a few moments here on The Defender in Depth. But first, let's take a look at last week's top headlines from The Defender. And we'll begin with a story from Wednesday, the 11th of September. Their vaccine injury reports disappeared from VAERS, the Vaccine Adverse Events Reporting System, so they developed a tool anyone can use to track their own reports. A story from Friday, September 13th, 60% of young people with COVID vaccine-induced myocarditis showed heart damage 6 months later, according to an FDA-funded study. In a story also from Friday, September 13th, the World Health Organization approves the first monkeypox vaccine for adults in Africa, but then says babies can get it too, despite there being no clinical trials. In a story from Thursday, September 12th, the UN's Pact for the Future. What does it mean? Digital IDs, vaccine passports, massive censorship, and more. In a story from Tuesday, September 10th, teen brains aged faster during lockdowns, and these outcomes were worse for girls. In a story from Monday, September 9th, the FDA blew off scheduled meetings with COVID vaccine injury victims, according to emails obtained by CHD. And a story from Thursday, September 12th, Dr. Marty Makary, medical groupthink harms patients and especially kids. And Marty Makary said this as part of introducing his new book, Blind Spots: When Medicine Gets It Wrong and What It Means for Our Health. Finally, coming September 18th, or today, Vax 3, which exposes widespread injuries and deaths following the COVID shots and the COVID hospital protocols. Those were our top stories from the past week from The Defender. Remember that you may find The Defender online, childrenshealthdefense.org/defender. And joining us now here on The Defender in Depth is former medical coder Zowe Smith. She's the author of My Life in the Thrill Kill Medical Cult. She will talk to us about a range of issues about vaccine injuries, about the COVID hospital protocols, about her new book, of course, and a lot more. So Zowe, good morning and welcome to The Defender in Depth.
Good morning. Thanks for having me.
It's great to have you on, Zowe, and you have such an appropriate name as well because Zowe means life in Greek, and we're going to talk about issues that have to do with people's lives and how they were impacted during the COVID pandemic. Let's begin with talking about what you were doing. You are a coder, or you were a coder. What does that actually mean? What does that actually entail?
So a medical coder a lot of people don't know what it is. It exists kind of in the background. You don't actually see the people that do this, but it's a field within healthcare called Health Information Management, or HIM. And there's a saying in health information management: if it's not documented, it's not done. And so everything that happens to you in any sort of clinical setting, it could be a dentist's office, it could be a hospital, it could be a doctor's office, it could even just be you go in to get a lab draw or an x-ray at a facility somewhere. And all of that is going to be carefully documented. I take that as a medical coder. My job is to take that information and translate that into diagnosis and procedure codes, which in the US are sent to insurance for reimbursement purposes. So that's how your hospitals, your clinics, and your physicians get paid, or at least it's an integral part to them getting paid. And it allows you to see any sort of financial patterns that are going on within healthcare. So you're really aware of any sort of payment changes, or even ultimately the codes, the ICD-10 codes, were designed to be a monitoring system for global patterns of disease. So the other thing that you're exposed to being a medical coder is obviously the patterns of disease going on in a population. That's one of the things they use the codes for, is to track how many cases of cancer there might be in an area or in a country, and how many cases of flu or any other kind of infectious disease there might be.
Now, you've also referred, Zoe, to your life in what you described as the thrill-kill medical cult. So it sounds like a bit of a contrast from doing this sort of bureaucratic work where you're coding for insurance and monitoring purposes. Where did this phrase thrill-kill medical cult come from? What experience did you have which led you to describe it in these terms?
Yeah, so I use that term intentionally. I call it a cult intentionally because of the indoctrination process that happens to everybody as they enter the healthcare field. And the reason I say that is because you cannot question certain things within the healthcare profession at any level, whether you are a janitor or whether you are a doctor, and every level in between, you are not allowed to question certain things. One of those things is the safety and efficacy of vaccines. Another one of those things might be the safety or efficacy of certain kinds of medications or procedures, especially anything around having to do with germ prevention and the stopping of the spread of disease. There's certain things that are accepted within medicine, and if you question or you make it known that you might not agree with any of this, you will be socially shunned. You will not be allowed to work. Often you will be fired. And I had a best friend that was, I knew her when I worked in a lab with her. And a lot of the people that I worked in the lab with ultimately went to medical school. So she went to medical school. We were friends the entire time while she was in medical school. And so during the process of this, I got to watch the indoctrination process take hold and how she changed over time. And then I noticed that it's not just the doctors in medical school, and I do think that's one of the strongest places for the indoctrination process. It almost has to be. But it's not just doctors. I realized, wow, we are all in the healthcare, we are industry, we are all steeped in this indoctrination process. And that's the main reason why I chose Thrill Kill Medical Cult. The other part of why I chose the Thrill Kill part is I wanted to emphasize that I do believe, after my experience, that they are trying to kill us. And I know that that's a triggering statement, but after going down the rabbit hole and looking into the information, the source documents, the formation of some of these regulatory agencies, the formation of the ICD-10 code system and what it was designed for from the outset, has led me to come to that conclusion.
So let's go down that rabbit hole some more, Zoe. There's a lot of people who have come forward and have said that their loved ones, their family members, their friends were killed in hospitals. We've interviewed many of these people in a Defender and on CHD TV. What do your experiences say to this? What did you see when you were in these hospitals? And did what you see confirm these reports and these allegations that so many people have come forward with?
Absolutely, absolutely, 100% confirmed what these patients have been saying, and I'm so glad that there are people coming out and saying this. I felt like it would be for me to come out and say this as a medical coder, especially someone who wasn't physically inside the hospital seeing patients every single day. I felt like no one would possibly believe what I had to say. And to me, it was incredibly obvious through the medical record documentation. Every note that happens between a nurse and a patient is documented. There's, social information that's documented. There's information from ambulance documentation that gets added to the medical record and becomes part of the medical record. So I thought that this story would be so fantastical that nobody could possibly believe. So I'm very glad that people are coming out and speaking out about it. Even when I was experiencing what I saw, it was almost unbelievable that this could even happen in a hospital, because we all believe that this is where people are supposed to go to get better and then come home after you've healed from whatever ailment it is that the hospital is supposed to help you. And that's not what was happening. At the very beginning, I noticed that the case numbers were not matching up. And then the PCR testing increased to where every patient had to have one. Right about that time, they stopped visitation, which I thought was just a crime against humanity right there. Hospitals are a very scary place to be in. And I have even heard, when I have been in the hospital myself with a loved one who was in the ICU, that nurse told me, and we had people with him 24/7. We did not ever leave him alone. He did not want to be alone in the ICU, and he was ventilated at one point. And his nurse came in and told us, and also this man could not drink water or eat food without help because both of his hands were broken. So he needed help with just that. The nurse came in and said, you need to have an advocate in the hospital with you at all times. As much as I like to care for all these patients, our duty has us doing so many different things that we're not able to do things like help a patient drink water every time they need to, or help a patient, literally bring their food to their mouth every time they have to take a bite. That's not something that they have the time to do. So she really encouraged us to do that. So when they stopped visitation, I thought that was horrific. That's making hospitals the scariest place to be on earth. This is when people need their support people, and we're kicking those support people out. And I also noticed I'm seeing all kinds of documentation from the police getting called to the hospital to kick out their support people that were trying to visit either dying loved ones or loved ones that were either being harmed by the hospital protocols and trying to get out. I started noticing other patients trying to escape the hospital, like unplugging things, pulling out vent tubes and escaping. And hospital security is sent to go look for a patient that's now missing. And then I started to hear the rumors about the ventilators. And I knew that there was a bonus for the remdesivir. And honestly, I didn't know how it was all coming together. But what I did know was before COVID, a cold, flu, or pneumonia case, you would normally be home within 3 days, maybe to a week, unless you had other major conditions going on. Kind of like what they were telling us at the beginning of the pandemic. You have to have all these other major comorbidities for you to be a severe case. Well, typically that's what would have happened with a pneumonia or a flu. But I had not known before the pandemic and the hospital protocols began, we did not connect patients to ventilators right away. It wasn't until they were in dire straits and we had tried every other non-invasive method that they would be put on a ventilator, and they would be coming off those ventilators as soon as possible. But I noticed that patients on this COVID protocol would be on the ventilators for 30 days or more sometimes, which was incredibly rare. And on top of that, they weren't talking about disconnecting these patients. from the ventilator, which should be something they're talking about within 24 hours, because the longer you're on, the less likely you are to come off the ventilator. And they know that. They know that this is a risk. And I also noticed that all of these patients were getting kidney failure within a few days of their administration of remdesivir, and that we had hospital protocols. I use that word, protocol. So they had a hospital protocol that was, if a patient was going to go on remdesivir, they knew that there was damage, a risk of damage to the kidneys with the use of remdesivir. So they had two consults. They had an internal medicine consult and a renal consult that was required, and patients had to be, they were denied the ability to be given remdesivir if they were chronic kidney disease stage 3 or higher. If they did not have chronic kidney disease and their labs checked out, then they could go on remdesivir. But the policy, the protocol said that, and this is even in the documentation for the drug remdesivir, if you go to drugs.com, it says this, that patients need to be monitored for kidney function while they are on remdesivir. So that's something that was even in the documentation, that we're monitoring this patient's kidney values. And I could see the lab values, and I could see that they are getting worse almost immediately after the administration of remdesivir. But that's almost like the physicians expected it, because they were told that this is going to harm the kidneys. So they were just trying to gauge how much they were actually damaging the kidneys. But as I noticed this pattern of patient comes in, patient gets COVID diagnosis, patient gets given a dose of remdesivir because that's the hospital protocol. Pretty soon they're on a vent. Pretty soon they have kidney failure, and then they're circling the drain, and nothing that we can do would save them. That was not a typical cold, flu, or pneumonia case. There was something very, very different. And that's when, even though I hadn't yet put together that the remdesivir led to the vents and made it worse, and the drugs that was associated with the vents were heavily used, and all those other things that we've now learned and found to be true, I just knew that the course of patients through the pandemic was not what we had done before, and this was killing people. And so I was warning people, do not go to the hospital. You're not going to get a support person while you're in there. You're going to be alone. You're going to be strapped down. They're going to put you on a vent. They're going to give you this drug, and they might not let you out. So I was doing the best I could to warn people early on, I think.
And everything that you described, Zoe, is very similar to the reports and the accounts that have been shared with us by hospital protocol victims. We'll talk about the vaccines in a few minutes. Hospital protocol victims that survived somehow, or if unfortunately in cases where these people did not survive, their family members who spoke with us, everything from remdesivir leading to kidney failure, to being strapped down, to being denied food or water or visitation from their loved ones, and so many other commonalities that have actually been compiled and show that there's this sort of remarkable pattern of similarities in the treatments that these individuals received, from the medication that they received, and also the way that doctors and nurses and hospital staff treated them and treated their families as well. We also interviewed people that escaped from hospitals, very much like you described, Zoe. So this all sounds very familiar. Having mentioned the COVID protocols, I think it's important for us to also talk about who set these protocols, where did these protocols come from, and what sort of monetary incentives were there for doctors and for hospitals to implement these protocols?
Yes. So what a lot of people maybe weren't aware of is when the world was asked to lock down, when the U.S. was told 2 weeks to flatten the curve, hospitals were also issued mandates. And those mandates were that they needed to shut down their OR, which is their bread and butter. That's where most of their money is made. And they had to reduce their ICU bed capacity, or increase their ICU bed capacity. So reduce the number of patients in the ICU beds. This is backwards from how hospitals are financially supposed to function. The OR is the bread and butter of the hospital. Without the OR, they pretty much can't function. The ICU is the one of, if not the most expensive wing of a hospital to run. And that's because there's incredibly expensive life-saving equipment in there. None of that's cheap. And then there's also many, many specialists that are on call 24/7 just in case a patient may require that. And that kind of labor is also not cheap. So hospitals have always tried to keep ICU bed capacity high because they lose money if patients are not in those beds. So this financially kneecapped hospitals for many months, from about March until May, when we were told we couldn't, we had to make room for this expected onslaught of COVID patients, which never came. During that time, hospitals were financially going down into the red. We were getting within 3 days of operating costs. The CFOs were starting to get really nervous about even being able to keep the doors open. And the CARES Act money had already been enacted, but it wasn't really being capitalized on. I feel like they were kind of practicing the hospital protocols at the beginning until they amped it up when they got it pretty well dialed in. Because I noticed at the beginning of the pandemic, there weren't that many patients affected by it, but as it got closer to 2021, approximately late summer, is when I really noticed that the hospital protocols had been amped up. And remind me what I'm getting at here.
Well, part of it also is where these protocols came from. Where did these, who developed them, and what sort of monetary incentives were there?
Yes, so that was the financial kneecapping. So the need for the money to come in was definitely there. So as we're getting financial reports of, actually, we were also getting laid off, and any sort of contract staff was being let go. There was furloughs going on. So when mainstream media was telling you that healthcare heroes were there because the hospitals were overrun, they were not overrun. That's where we got the dancing nurses from. And people were actually being laid off, cut off, losing their jobs, having to go on COVID support or unemployment support, and these kinds of things. So when these bonuses came in, there was a huge incentive to use them. And those bonuses, I was first aware of the one with remdesivir, and that was very key around the hospital protocol. I'm not entirely sure, who or how the hospital protocols were devised, but they came down to us from the NIH. It was in the NIH COVID treatment protocols that said, this is what you're supposed to do. Remdesivir was in there, ventilator use was in there. It said that patients may spread disease just by spittle or breathing if they're in the hospital at all. And that's one reason why they went straight to the ventilator rather than normally they would start with a nasal cannula, which is just a thing that goes under your nose. And then maybe they would work their way up to a mask or maybe a CPAP or a BiPAP. And then if the patient still cannot oxygenate at over about 85% or higher, then they would consider putting a patient on a ventilator. But for the protocols, they went straight to the ventilator, even before patients had dropped their oxygen saturation to the threshold where we would normally ventilate a person. So they even raised it to where patients that were in the 90s for oxygen saturation, which is acceptable, would be put on a ventilator, which had never happened before. So I believe that the hospital protocols evolved, basically, and every hospital kind of had their own little nuance on it, but it came from the NIH, and they all followed it to the letter. My hospital did, and I knew that across the country, they were all following it to the letter. And it was, you come in, you get your COVID screen. If your test is positive, doesn't matter if you have symptoms or not, they're going to start COVID treatment, which is going to be the remdesivir. And then very soon after that, the ventilator treatment. Now, the bonus part of it, I was aware of because as a medical coder, when you send something out to billing, if there's an error, sometimes we have something called a stop or a billing check. It's built into the program. So you can't send a bill out or you can't send a claim out unless you fix certain things. And one of them was the remdesivir administration, which was not something that an inpatient coder, which was my my role at the hospital during the pandemic, normally we would not even apply procedure codes. That those would be automatically done in the background. But for COVID, for the remdesivir, there was a new tech bonus. And a new tech bonus is something that normally comes in. It's not actually adopted into the official code set for a few years. It's sort of put off to the side as an experimental thing. And the reason for that is Medicare doesn't have multiple years of safety studies to go with it. It's usually they call it a new tech because it's usually a new device coming in that hasn't been used yet. And a lot of times these devices are part of a study and they're that new. Well, for remdesivir, it was a new tech, which isn't really a device or a technology, but that is the section that it was put in. And Gilead, the company that developed remdesivir as an Ebola drug with the NIH and Dr. Fauci, and they found that out of this study, there were 4 drugs, and remdesivir killed 53% of the people. They actually stopped the study because remdesivir killed so many people in this particular study. And yet this was the drug above all the other drugs that was used for the hospital protocol. And Gilead applied for a new tech bonus. So on top of hospitals now needing to apply this remdesivir code, which was odd, now there's this new tech bonus. So they got 20% for every single dose of remdesivir that they gave to a patient. And then, of course, they got the bonus for it being a COVID patient to begin with. And then if the patient goes on a ventilator, which is pretty well guaranteed, I would say, at this point, after being given remdesivir, at least within a certain period of time. Some people made it without, but a lot of times it led to the ventilator. And being on the ventilator puts you at the highest payment category so that they got the maximum payment. So I believe that's how it evolved. I believe it was a financial incentive, started with 3 months of not having anybody in the hospital. And then the CARES Act was enacted and this new tech bonus came out for remdesivir. And then they all came together and hospitals realized if we use this protocol, we're going to make tons. I mean, I didn't actually see the bills coming back in. And to me, that's still incredibly baffling that I was in medical coding, but they have everything so siloed that I never saw the actual bill that went out. So although I could see the charges that were on the account from the charge master, I didn't know the actual number that was being billed to insurance. And I never saw the numbers that were coming back from insurance on what they were actually paying on these claims. But I can tell you that when people say that some of these bills were over $1 million, that is correct. And if there's $30,000 to $60,000 in bonuses, I would completely believe that, just based on my understanding of the DRG payments, insurance payments, and the difference between the charge master. But to this day, I really wish that I could have seen all of those pieces come together so that I could be here and explain to you how those numbers come out. So I'm trying to work with other people to narrow that down because that information is out there. We just need to flesh it out.
Well, that was a very comprehensive explanation, Zoe, and I think we all appreciate that. You really connected the dots there. We'll come back to coding. I have some other questions about it, but I wanted to ask you what you observed in hospitals specifically with regard to the COVID shots. What did you see in terms of patients, how they reacted to those shots, if they got injured to those shots? What was your experience?
Immediately when the shots began to be rolled out, and it was going to be within the hospital, it was going to be the ER staff, the doctors, the ambulance, those were the first responders, and they were the first ones available to get vaccines. And it was early December that we began giving those out. And every country or every hospital across the country was incredibly behind in their medical coding at that time. So even if a injury case had come in at the beginning of December, I wouldn't have even seen it until January. That's how far behind we were in our workload. But as soon as January rolled around and I had the opportunity to see any number of cases that could have possibly been in the group that was eligible to get the vaccine, I began seeing some incredibly crazy cases. There was a case of a woman who had just seen her daughter a few minutes before, and then the account said that an ambulance was called. She didn't call the ambulance herself, but somehow an ambulance was called. I don't know. I don't think her daughter did it. Maybe she did it, and then she passed out. Documentation wasn't very clear on that. But when the ambulance arrived, she was in her own mess. She was unconscious, multi-organ failure, and died very quickly at the hospital. And I began to notice more cases like this of near instant death, like within an hour, of multi-organ failure, massive inflammation, brain death, things that we had never, ever, ever seen before. In my 11 years of medical coding, I had never seen a case like that. And the strangest thing to me was I thought the second this vaccine went out, everyone on the frontline staff should be asking patients, did you receive the COVID vaccine? We know it's emergency use authorized. We know it's experimental. So obviously there could be problems with it. And I felt like they should be watching. It should be their duty to do their research and learn the kinds of things that might happen from a new drug like this, and then be prepared to deal with it. So I had done my research. I had followed the clinical studies and tried to figure out, well, what kinds of things would we be seeing if a patient had received one of these shots and then did not have a good reaction to it. And I was seeing all of those things, but doctors were it seemed like they weren't asking the right questions to find out if these patients were vaccinated or not, at least to me, and they weren't writing it in the medical record. And that should have been something that would have been question number one, I thought. So that got my hackles up, that there's something going on here. Because I couldn't even prove if these patients were vaccinated or not. But clearly to me, something was very different in that these patients had a life-changing, massive health emergency that occurred within a few weeks of the rollout of this vaccine. And then before long, I started to see more and more cases like that, and they started calling it sepsis. So there were these massive cases of sepsis, and the documentation began to say that doctors and nurses were asking patients now, have you gotten the vaccine? And the patient would very proudly say, yes, I got it. I got it on this day. I got this brand. And most of those patients that had the sepsis and the massive whole body inflammation did not make it. There were a lot of cases of seizures that were uncontrollable. There's a code for status epilepticus, is what it's called. And I've never been able to assign that code before the mRNA injections went out. That is when the clinical definition is you have to be having a seizure for so long, and there's like a certain period of time where you have to have a continuous seizure. And on top of that, it has to be non-responsive to any sort of drugs. So there have been very severe cases of seizures throughout my career, but I've never, ever been able to apply that code until the mRNA injections came out. And more people arrived with this condition. And then people started to arrive with brain inflammation, encephalitis. Some of them also suffering from seizures, some of them suffering from stroke-like symptoms. There was a massive amount of strokes coming in all of a sudden, massive blood clots coming in. And these were in young people. These were not elderly people with comorbidities. These were young people that were eligible for the shot. All of these first responders would have been within working age. It would have been late 20s to maybe 60, a little under 60, somewhere in that range. Well, most of these were in their 30s or 40s, very healthy people with no chronic conditions. And then all of a sudden, they're in the hospital needing a leg amputated because they have a massive clot And when we go in with catheters to remove the clot, they can't get it all out. There's just so many clots that they end up having to do a vein graft, and sometimes that wasn't enough. And then within a few days, they're having to amputate because there's no blood flow to that extremity. That never happened before. And over a few months, I started to notice, the strokes, the seizures, the sepsis, which was rampant at that point, the blood clots, turbo cancer started to roll out. Patients that had cancer cleared for 10, 15 years and had been declared you're cured, but they still do monitoring. Those patients would come back and with cancer worse than they've ever had it in their entire life, and they would be dead within a few days. And cancer had never progressed that fast. So just within a short period of time, it's almost like the entire caseload changed to these life-threatening, severely injurious reactions to the vaccine.
And Zoe, this matches so much of what we've heard from vaccine injury victims that we've interviewed or their families. At the same time, in other interviews that we've done, we've also heard that the unvaccinated received a sort of special treatment as well, and in a negative sense of the term, when they went to hospitals with COVID-like symptoms, oftentimes with very minor symptoms, and that doctors and nurses were very insistent on asking about their vaccination status. We also had an interview that was published in The Defender a few weeks ago, where the wife of someone who ended up dying in the hospital, and he was unvaccinated, but he was placed on a ventilator for quite a number of days. So the wife of this COVID protocol victim was also saying that when she reviewed her husband's medical records after the fact, she noticed, and then she confirmed this by speaking to some people at that particular hospital, that patients were either listed as unvaccinated in the medical records or as unknown, vaccine status unknown. And her feeling was that this was being done to obscure the actual extent of vaccine injuries by sort of hiding those injuries under unknown status. So are these sorts of things experiences that you also had as well, Zoe?
Unfortunately, I didn't have direct experience with that, although I do believe it to be true, and I can tell you why. As a medical coder, one of the things that I had to do was assign an injury code for every injury that came in. A vaccine injury would be one of those. There is a code for place of injury. So if it happened at home, if it happened at school, and those are statistics that are collected. So you can see, like, that's kind of how they find out that ice road trucking is dangerous, and they know how many accidents happen. And hospitals can be fined, and my hospital was fined for not reporting the place of injury on every case. It's state data, and it's regulated by the state, so you have to send it depending on your state. Some of them are more strict than others. I was in Arizona. They're one of the stricter states about that. So I thought for sure, and there are questions that are set up in the electronic medical record for the front house staff. So for the nurse that's doing triage, when you come in to an ER and you talk to a nurse, they're writing everything down about, your past medical history. Well, there are prompts that are written into the medical record to tell the nurse what to ask and where to put that information. So one of my jobs at one point was to speak with the other areas of the hospital, the tech software and all that, and figure out how do we get these prompts built into the medical record so that these nurses will ask the right questions. And it was like pulling teeth, and I know that's a pun, but it's accurate here, to get those questions put on in the program so that nurses will actually be prompted to ask that information. Because they don't know that we need to collect that information on the background. They're concerned about the actual patient care, and they find answering questions like that to be just a time suck, which I understand on one hand. So that is how those prompts should be built in. And I thought as we approached 2021, we knew Operation Warp Speed was going on. We knew the vaccines were coming out, and there's no way you could have missed that unless you were maybe living under a rock. So I thought for sure we should be prepared. We should have those questions built in to the record already, and they were not. And the official definition of if you were fully vaccinated, which I was following, was you had to have both of your shots, and you had to be 14 days past your second shot to be considered fully vaccinated. So these patients that were coming in with just one shot, or even two, but they hadn't passed that 14-day window yet, so they could have had a shot for up to 30 days, and they would have been considered vaccinated, but they wouldn't have been considered fully vaccinated. And I don't know if that's the loophole they used to not put those questions into the program. I believe the program is called EPIC, and I would like to find out how we can get that information from them. When did they start putting these prompts in, and did their clients specifically ask them not to add an option for fully vaccinated? Because it's a very, very simple thing. If you've developed a website or you've done any sort of electronic media, it's very, very easy to add in something like that. And it to me appears like it was intentional, that they had only the option for unvaccinated or partially vaccinated, and they didn't even allow the option for fully vaccinated. And that made the statistics appear as if everyone who was coming into the hospital and being harmed by the hospital protocols, or anyone who came in with a vaccine injury, was being categorized as the unvaccinated. And we know that the mainstream media was telling us, gaslighting us, that it was the pandemic of the unvaccinated. And so the medical record program software seemed to emphasize that. That was not happening at my hospital, which is why I say I don't have direct knowledge of that. At that time, it was up until April 2021 is when I quit my job over the vaccine injuries, and I knew that the mandates were coming. So there was only about a 4-month period, and it was very early on, so they may not have enacted that until slightly later. Most of the stories that I hear are late 2021, and I know how these things get rolled out. Once one hospital picks it up, another hospital would pick it up, and then it would go pretty quickly across the whole country. But I don't think they were doing it right at the beginning. And that's why I said in my interview, I believe they were trying to hide that information from us right at the very beginning. But then when they rolled these questions out, which apparently didn't take more than a few months, it very clearly enabled a way for them to make it appear like it really was a pandemic of the unvaccinated.
So you mentioned, Zoe, that you quit your hospital job in April of 2021. Before doing that, did you try to speak to anyone on staff, to management, to administration there? Did others, any of your colleagues, see these things that you've described? Did they speak? And if you did speak out, what happened?
Yeah, I did try and reach out to some of my coworkers. Now, I worked remote, and so everything was being watched. And I knew from being in a supervisor role that IT has the ability to see everything that you type. So we had like a Skype instant messenger. And if I typed something in there, I knew IT could see all of that, pull that information and use it against me. And we're also on a production standards, like every type of coding, you have to do a certain number of charts per hour or they can fire you because you're not doing your job well enough. So coders are highly incentivized not to talk to each other for various reasons. But I still reached out as much as I could and tried to ask some questions. My coworkers were seeing things, but they were keeping their head down and not asking questions. I had worked with my manager in person at the time because we used to be at the same level. I had actually stepped down into an inpatient role because I didn't want to work on a salary position as I wanted less hours. So I was doing inpatient coding, but I had been at the same level as her and we were close. So I thought I could reach out to her as a friend. And I had asked about the census and how the census was removed so we couldn't see it anymore. And she agreed that that was strange, but you kind of brushed it under the rug. As I started to ask more questions about especially late 2021 late 2020, summer 2020 is when normally summer is the lowest volume for our hospital. I remember being a supervisor and sending patients home because we didn't have enough work for low workload. That's normally when people go on vacation. We'll send out educational things just to kind of give some busy work, because in the South, in the summer, no one's there. They all leave, and then they come back in the winter. So that's our slowest period during the entire year, but we were busy at that time. So I began to ask her, can we compare these numbers this year to the previous year? And she would just respond with, it's not a big deal. We're at the same number as we were before, but not share that information. So I began to think, okay, they know what's going on, but they're not telling me, and they just want to keep collecting their paycheck, and so they want me to keep my head down and not ask any questions. So then I began to ask some of my coworkers, well, previous coworkers that worked on contract status across the whole country, have you seen vaccine injuries? Have you seen these hospital protocols? And I didn't call them that because I didn't want to trigger them, but I wanted them to tell me if they were seeing some of these crazy cases, like the sepsis or the seizures or the blood clots. And of course, they confirmed that they had been seeing all of these things and that it was abnormal for sure, and that the volumes across the whole country were abnormal, but they weren't speaking out about it. They were even nervous or skittish, I guess, even just to respond to an email. That's how discouraged they were from speaking out. At that time when we had furloughs, I remember hiking with my friends a lot, and they were all also healthcare workers that had been put on furlough. So we all suddenly had a whole bunch of time on our hands, and it was summer in Arizona, so it was a great time for us to go hiking. And while we're out there, I would ask them things like, what are you seeing in your OR? What are you seeing in your hospital? Obviously, their volumes were not high enough, so they were put on furlough also. So I knew this wasn't just my hospital. This was going on everywhere. And they had started to ask questions. One of the girls worked in OR, and she said one of the things that they would do is when the patient goes under, the COVID protocol was they had to go out of the room for 15 minutes because the patient had to exchange all this air while no one was in the room. And she said, that makes no sense to me, because when you put a patient under anesthesia, that's the highest risk point to the patient. If there's going to be a reaction, it's typically going to be within that window. And so you're giving them this dangerous concoction of drugs, and then you're walking out of the room and hoping for the best. How is that going to work out for the patient? So they were questioning things, but then it really didn't take too long. I think within maybe 30 to 60 days of the 2 weeks to flatten the curve, and they all got on board. They stopped asking questions. They stopped allowing me to ask questions on the hike. I was actually uninvited from multiple hikes just because I was continuing to ask questions and trying to get answers from them. So the more I asked anything, not even anything very triggering, the more I was basically told, keep your head down and shut up. And when the vaccine mandates came in, I knew from being a medical coder, and I had filled out the flu exemption for many years. So I knew about the flu shot policy and the exemption policy. This is the part that many people that work in the hospital were not aware of, because this is a Medicare policy. It's part of their quality monitoring or patient safety net. They consider it a safety or quality marker if your hospital staff is getting vaccinated for their flu every year or not. So Medicare had a policy for the flu shot for many, many years that hospitals had to vaccinate their staff 80%. And you could fill out an exemption, either medical or religious, but I think only 20% of people could fill out that exemption. They had to have 80% that was actually vaccinated to receive their money. So there is an incentive, there is a financial incentive. If hospitals did not vaccinate enough of their staff with the flu shot every single year and certify on paper and send that information to Medicare in a data file, if they did not do that, then they would be cut up to 6% from every single payment that Medicare makes for every single patient, which would bankrupt a hospital. It would be millions of dollars. to lose out on that kind of money. So they were very, very serious about getting their flu shot, even just the exemption that I had to sign. I had to sign it every single year, and I had to fill it, submit it to Medicare every single year. And I would get reminders if I didn't do that. So I saw that they were creating this policy for COVID, and I even saw on the paperwork, it said now 100% of hospital staff has to be vaccinated, and this includes vendors, people who work from home. It doesn't have to be just face-to-face, in-person care staff. Anybody who is even loosely associated with a hospital is required to vaccinate. And for COVID, they changed it from 80% compliance to 100%. And then they changed the exemptions to now they can question if you have a religious exemption. They made the form about 5 pages long when it used to be just 1 page. And then the medical exemptions, they made it near impossible. You had to actually get the COVID shot, the whole COVID shot, and have a reaction that your doctor documented as a reaction to the vaccine. All of those things are near impossible to have happen. And then you would need to submit a form from your doctor saying, yes, you've already had a reaction to that. And now I see the CDC has a policy saying, if you've had an allergic reaction to the Pfizer one, you can get the Moderna one. Or they still want you to come in and have a physician give you the vaccine, and then the physician will be there to give you antihistamines and steroids and help you with the anaphylactic reaction that you might get. But you should still get vaccinated, is their official advice. So when I saw that happening, and there were videos of the hospital leadership saying specifically, people like me who worked from home, we were the problem. We were spreading COVID to everybody and killing grandma. And we were going to lose our job if we didn't get vaccinated. And obviously the hospital was doing this for money. They would lose a lot of money if they didn't do this. And so rather than allowing them to fire me and then being left without a job and not knowing how I was going to make ends meet or feed myself or house myself, I decided I would try and stay ahead of the curve, and I was going to go ahead and leave before that happened. So within about a month of that policy being enacted, and they already had the mandates, they already had the notification saying you will get fired if you don't get this done, and here's your due date. So all of that was already going on, and I wrote up my resignation letter, and they knew I was already asking questions. This hospital had me keep an employee who went around to multiple other departments within the hospital and back-talked the management of HIM to everybody else across the hospital. They were known to be committing financial fraud, which I had to report them on as their supervisor. And we kept these staff. There were staff that violated HIPAA that we kept. We did not fire them. We kept them. There was a woman who was falsifying birth records. She was kept on for a year before we could terminate her for cause. So I knew that when I went to put in my resignation, I thought they would fight me to stay there. And we were on mandatory overtime. So I knew they were in a crunch to have staff there, and they weren't hiring anybody. So they needed people that were already trained. So I felt like between all of these things, they're going to ask me to stay. And I put in my resignation letter, I will work part-time until you can fill in my position, but I'll at least work per diem X many hours per week, but I already have a commitment to another job, and so I'm only able to do this many hours per week. They actually emailed me the following day after I submitted my resignation letter. They said, I gave 2 weeks notice. They said, would you like to quit early? Because you can quit today. And then they actually cut my access to the medical record before I even had a chance to answer. And by the next day, I was out. So it was obvious to me. They knew that I knew something, and they were trying to get me out of there because they thought that I was a liability.
Thanks for sharing that, Zoe, and we're getting close to the end of the interview, but I wanted to ask you before we close out a couple of final things, one being how you've turned these experiences that you had into what you're doing now. So tell us about the book that you just published and everything else that you're doing currently.
Yeah. So I have a book that just launched on Friday. It's called The COVID Code, and it's about the COVID diagnosis code, my life in the thrill kill medical cult. It's already been censored. My website's come down and gone back up, and the Stripe banking payment systems already shut me down. So they don't want you to know this information, apparently. But after I quit my job in the hospital, I started going down the rabbit hole and looking for the truth and trying to put everything together. And I felt like what I just experienced was a Holocaust. This was a genocide. I didn't know if I could live with the weight of what I had just experienced. I honestly didn't know how I was going to go on with this. It was trauma. I think I have PTSD from that experience. And in talking to other people, I learned that a lot of people have an idea of some of what happened, but maybe not everything that happened. And just being in the position that I was in, I call it the Sim City level view or the CIA of the hospital, it sort of allowed me to see everything at once in real time and really be able to compare that to what mainstream media was telling you and then what was really truly going on within the hospital. And when I was in a training position as a medical coder, a lot of my staff came to me and said, you have the ability to explain these really difficult concepts in a way that makes sense. And after I experienced all of this and I had all this grief from all this death, I thought I need to turn this into something positive. And as I started talking to people and realizing they don't know, I thought maybe I can use my skill of explaining something that's complicated. Maybe I can take this information and put it out there so that people can be warned and they can know what's going on. Maybe they won't go to the hospital anymore. Maybe they won't trust their doctor. Maybe they'll do their own research before they just blindly listen. And really, to me, it's about saving lives, and it's about helping us figure out what happened. So I tried to put everything that I could about my experience in there, so that my feeling is that not all of us have the whole truth, and I don't have all the answers. I certainly tried to put as many as I could in that book, but I feel like we all have a piece of the puzzle. And so that's what I really wanted to offer, was a way to package the experience that I had, the firsthand experience that I had, support that with some historical information, some scientific information, because it was incredibly surreal to be living through what I did in 2020, that it seemed like no one knew was going on. And then have that information come out into light, and then have all the science come out and prove that what I was observing was actually happening. Because it was so surreal, I was questioning it the entire time. And now I'm sure of what I experienced. And so it's now my life's mission to warn people, because this can never happen again. This shouldn't have never happened. And if by saying something, if by writing this book, I can warn people and I can help illuminate some of the questions, I guess, if I can help answer some of the questions that people might have over the whole COVID experience. And also I know that there's going to be generations that come down the road that are going to want to know what happened. And so I write this for them too, because if they can't ask their parents, or if all the information's been censored off media, which I expect, then at least there will be something physical that someone can turn to, and hopefully it will help them answer their questions about what happened.
So the importance of warning people, warning the future generations as well. Final thing we'll discuss before wrapping up today, since we always like to end on a positive note here in the Defender in Depth. Today's Vax 3 Day. Vax 3 is being released today in selected theaters across the U.S. You've had the opportunity to see Vax 3 in advance. What would you like to share about it with our audience?
Oh, wow, that's a good question. I'm just really excited for everybody to see it. I think there's going to be a lot of incredible information in there. The human piece, the piece of people telling their firsthand stories, and then supporting that with the medical whistleblowers like myself. It's a really, really powerful story. They've taken an incredible, we've lived through some incredible times. And so they've really told the story well. They've done justice to all of the people that were harmed by this. They explain the financial incentives incredibly well. I learned a lot actually watching it. So I know it is a dark topic, but I felt like this one actually, the way it was presented wasn't quite as dark as maybe the first one when I watched it. So I really enjoyed that part. That I know I was so nervous to watch the movie because the first two left me just crying. I just thought, like, how can all this destruction happen and no one knows? And but this one left me with a lot more hope because I think a lot more people are waking up. And it's hard to describe, but the way it's presented, it walks you up to the parts that really tug on your heartstrings. But before it gets to the point where you can't bear it, you go off to another topic that's a lot more positive and uplifting. And I really love how the movie ended on a positive note because it's such a difficult topic to actually pull off a positive note. But I'm seeing a lot of hope out there. I'm seeing a lot of people waking up. I'm seeing a lot of people who want the truth, a lot of people who are questioning things that didn't question things before. And that gives me a lot of hope for change.
Thank you for that, Zoe, and you're helping to contribute to that as well. So thank you so much for joining us today on The Defender in Depth and for sharing your own experiences with us.
Thank you.
I'm Michael Navardakis. This was The Defender in Depth. We are on the air Wednesdays, 10 a.m. Eastern Time, 9 a.m. Central. Our podcast is available on Spotify. Remember that you can follow The Defender online at childrenshealthdefense.org/defender. We are on Substack at tdefender.substack.com. We are also on X and on Telegram as Children's HD. And remember, today is Vax 3 Day. Be sure to check it out with more information available to you at vax3.org. Thanks for joining us. See you next week.
It's a nightmare. It's a nightmare.
I ended up in a wheelchair.
Completely seized up, thought I was stroking, couldn't walk.
Had to relearn how to walk again.
His kidneys are shutting down. She had 5 Pfizer COVID vaccinations. She never woke up.
This is the life that I have now. It's when you start thinking, okay, how do I end my life?
Something really sinister, really sinister was going on.
These were fundamental violations of human rights.
So we here at Children's Health Defence are going to go back out on the road. We are going to speak to every single one of you. What have you been through?
Those are my eyes. This is a huge tumor.
This is the bottom of my lung that is filled with blood.
They said it was the most aggressive cancer that they've seen.
I held on to my husband for the very last time, and I stayed with him until his body got cold.
I told him that I loved him, not to be afraid.
What have your children been through COVID, through all of the issues that we've had over these last few years? We want to hear all of your stories.
It was hard seeing 25-year-olds coming in with heart attacks, with strokes, because they received the vaccine.
The success rate of these patients getting better was next to zero.
There's something wrong. There's something has happened, and you have to consider the vaccine.
This is a pandemic of the unvaccinated.
You showed up here and you're unvaccinated, you will suffer for having not done what we had to do.
That, to me, was a crime against humanity and a violation of my oath.
We will continue. Children's Health Defence will continue, and we will not stop until there's justice, and this never, ever happens again.
Have you signed up for CHD's brand new community forum? Join this one-of-a-kind online community and engage with like-minded individuals. Discuss issues that are important to you and get answers to questions you won't find anywhere else. Membership is free until October. Sign up now to start making new connections today. This and all CHD TV programming is made possible by generous support from viewers like you. Please consider making a contribution today to keep our programming going strong. Thank you.